CoQART, which is the resveratrol, which is a rejuvenating formulation. So with this, I'll request my Senior General Manager, Mr. Manoj Joshi, to give his welcome note. Manoj, over to you.
Yeah. Good evening, all respected doctors, and very thrilled and excited to see the eminent panelists. And I'm sure that the audience is connected in hundreds and bigger number. And I must share that when Dr. Santosh Gupta approached our team that if we can support for the scientific activity, and we are more than happy. And as rightly mentioned by you, Doctor, whether Dr. Manish is there, Napoli is there, and all our team at UNS, our strength and backbone is science. And we've always believed that we should partner with doctors to ensure that we disseminate the facts in the right way and make our brands which are truly and genuinely for the patient benefit. Thanks once again for giving us a big opportunity like this, and we look forward for many more events like this. And couple of things about UNS, Doctor. We were with Sanofi for more than 12 years. 2021, we came out as a separate organization with entrepreneurship mindset, and we have built brands. This company is known for CoQ. CoQ 300 has successfully completed 25 years. Then we have CoQ range, CoQMAN, CoQ 4, CoQ LC. All of you are supporting us in a big way. And recently, there is a new member added in our product portfolio, that is CoQ Art, Doctor. And I must share that my colleague will be reaching out to you, and some of the doctors, they would have reached out that CoQART is nothing but resveratrol 150 milligram and lubicanol 100 milligram. It comes with a novel combination and a very unique technology, which is called as Phenomate technology, ensures and proves a big problem of resveratrol having absorption and bioavailability issue, which is ranging between 1 to 5%. So we use more than 90% absorption with resveratrol using CoQART, particularly in diminished ovarian reserve and the failed cases of IVF of 35 years. And all over, this is the company who has built the brand, iconic brand like Primosa and co-created 25 years. We have original bacterial source for CoQ 300 success rate, and the outcome with, while using CoQ is pharma, and I'm sure that as
Sure. I think we have lost Manoj. Ma'am, should we pass it to you? I pass on the proceedings to Shilpa Madam for taking it further ahead. Ma'am, over to you, ma'am.
So good evening. I'm Dr. Shilpa Harish, Chairperson of Kasuga IRT Committee. Today, I welcome you all for a webinar on enigma of infertility. First topic being genital tuberculosis, an enigma, and PCOS, demystifying enigma. Welcome all of you. Arun, can we have the prayer?
This one, or which one do you want?
Shilpa, prayer song. Shilpa, prayer song.
Yeah, I have
Arogyam dhana sampadah shubham kurutvam kalyanam Arogyam dhana sampadah shatru buddhi vinashaya Deepajyotir namostute Deepajyotir namostute Shubham kurutvam kalyanam Arogyam dhana sampadah Shubham kurutvam kalyanam Arogyam dhana sampadah.
Yeah, Dr. Shilpa.
Shilpa, we can introduce chairpersons now.
Now I invite Dr. Durgadas sir for a few words about our program, sir.
Good evening, everybody. At the outset, I congratulate the Infertility Committee, Dr. Shilpa, Dr. Anuradha, Dr. Santosh, the whole team. You are doing marvelous job. Without interruption, every month you have given the programs. In fact, this is what work you do. You do is indirectly is a. I am getting the credit for that, telling that your chairpersons are doing wonderful jobs. Out of the 12, more than nearly 8, 9 people are doing wonderful job. One among them is Shilpa and her team. I really congratulate you for that. Coming to the today's topic, the day of enigmas. First is about the enigma of genital tuberculosis. Second is the enigma of PCOS. You have taken one very good topic. Beyond that, icing on the cake is Sonia Malik, madam. Madam, Kasoga is honored by your presence today. Really, you're a great teacher, great clinician. We have a lot to learn from you. Your each and every slide is a great message to all the practitioners.
Thank you so much. Really, thank you.
Kasoga, thanks you a lot for spending time with us today evening. The next is the panel going to be moderated by Santosh Gupta and Shilpa. And the panelists, Dr. Vidya, Rubina, Ashwini, Shaviz, Chandana, Sujay, and the great experts, my good friends, Lavanya Kiran and Anuradha. I know definitely those who are attending are going to have a good feast this evening. With these few words, all the best, Shilpa. Please go ahead.
Thank you, sir.
Thank you.
So let's look forward for an enlightening program today. Dr. Santosh, please take over and welcome Dr. Sonia Malik, madam.
Thank you, Dr. Shilpa. Nakul, please show Madam CV. It's great pleasure and honor to introduce Sonia ma'am. And it was really a great pleasure that I could invite Sonia ma'am for this podium, and the entire Karnataka is benefited by her talk. And Sonia ma'am's CV is very, very elaborate. Above all, she's our chief clinical mentor. We work together in NOVA, so ma'am is our chief clinical mentor. And madam has many positions like past chair infertility committee, past president IFS, past president Indian Menopausal Society, chair infertility committee, vice president IMA South Delhi, Indian representative of International Menopausal Society, Indian representative of Asia Pacific Society.
You can leave
it's very, very long. So, and madam has many awards, among that few lifetime achievements awards also madam got. So I think now we request madam to enlighten all of us. Thank you, ma'am, for being here.
Thank you very much, all of you. First of all, Dr. Durga Das, thank you so much, not only for making me come here and interact with all of you, but also for the kind words that you have spoken. Thank you so much. Thank you, Dr. Shilpa, for having
Thank
me.
you, ma'am.
I request Dr. Shilpa, please mute yourself.
And of course, Anuradha, Santosh, every one of you, each one of you. And more than that, I would also like to tell you that I also have been a very great fan of coenzyme Q10, especially this brand CoQ300. I'll let you know why. I was teaching this is many years ago, about 15, 20 years ago, I was teaching my daughter, the Krebs cycle and biology for her 10th class. And then I saw that this molecule was there in that. And a couple of days before that, somebody had detailed me on this molecule of coenzyme Q, and I thought it's just any other nutraceutical. What are they talking about, Didn't pay any attention to it. But then when I saw it in the CBSE book, I was really so convinced that, these are small molecules about which we do not know much, but we should pay more attention to them. And now look where it has grown. Congratulations, Dr. Manish. Your product is doing extremely, extremely well and helping us also. So with that, let me come back to this enigmatic topic, as you all say, but I think it's, we've actually solved the mystery to a large extent. I will just share my slide with you, just a moment. And then let us see what we can do about this product, this problem that we are facing day in and day out. So I speak today about genital tuberculosis and how to solve this enigma. We all know that, probably we don't know, some of you don't know that it was also mentioned in the Ayurveda about 3000 BC by Charak in his own testament. And then many centuries later, it was attributed to Robert Koch, who discovered the organism Mycobacterium tuberculosis. But we should give some acknowledgement to our own people also, because it was known to all of us. And then, of course, even now, after so many centuries, it is still ranking as one of the most important communicable diseases of the world. And it takes 1/5 of the deaths in females is because of tuberculosis in the world. But more than that, what is important for us today is the fertility angle of it. And this clinical interest was actually an accident which was aroused because Sutherland in 1932 looked at the tuberculous bacillus in the endometrium, and that is what started the whole ball game. And that is how we are now talking about this extrapulmonary source. But today I will talk to you mainly about the developments that have taken place from the year 2016 to 2025. There has been rapid strides in the diagnosis and treatment of tuberculosis, and more than that, the approach to extrapulmonary tuberculosis. So, most importantly, what happened in 2016, we came out with these index TB guidelines, which helped to define female genital tuberculosis. There were developments in the understanding of the disease, guidelines for diagnosing, lapses in diagnosis, and management of female genital tuberculosis from the fertility perspective. So all these developments have actually taken place after 2016. And this is what the Index TB guideline, this was the group led by WHO, and it happened in All India Institute of Medical Sciences under the DOTS program as well. So these index TB guidelines were actually set out for extrapulmonary tuberculosis. So with those, you can now define extrapulmonary genital tuberculosis also as other extrapulmonary cases, So the case definitions are: what is presumptive extrapulmonary tuberculosis? Patients who need to be investigated, say for genital tuberculosis, people coming with infertility and menstrual problems or a tumor, etc. What is confirmed tuberculosis? Presumptive cases with any laboratory test positive, that is AFB smear, culture, histopathology, or if laparoscopy has positive findings, definitive tuberculosis, presence of tubercles, caseation, and beaded tubes, and will be treated with ATT. Tissue specimens are obtained from the endometrium, peritoneal wash, fluid, biopsy, or suspicious site. Now, these guidelines are found on the website of the Ministry of Health for Tuberculosis Health and Family Welfare Program, and you can always get them from there. But it is important for us to understand this because we have to label our patients into some kind of a category. What is probable tuberculosis? Presumptive cases with no microscopic or histopathological confirmation, but with a strong clinical suspicion. Laparoscopy suggestive of the presence of straw-colored fluid in the pouch of Douglas, hyperemia of the tubes, etc., will also be coming in the category of probable tuberculosis. And laparoscopy suggestive of extensive dense pelvic adhesions, etc., after excluding other diseases, will also be considered as probable tuberculosis. A positive PCR with laparoscopy findings like flimsy adhesions, etc., may also be considered as probable tuberculosis. Remember, this is not confirmed tuberculosis, positive PCR with laparoscopy findings. It is still probable tuberculosis. What about cured cases? If we had initially diagnosed them with microbiology or histopathology, now when the patients become negative for those respective tests at the end of ATT, they are considered cured. If initially diagnosed with laparoscopic findings suggestive of active TB, again, a negative relook laparoscopy considers it as cured. And finally, a resolution of clinical symptoms. So if it is infertility and your patient conceives, it is cured. If it is recurrent miscarriage and your patient continues with her pregnancy, she is also considered cured after the end of ATT. So these are the case definitions which you must know in order to label your patient. Now, most importantly, what we have also realized with the coming in of these different thoughts after 2016 is that TB is not just yes and no. TB is not just latent and active. It is a spectrum of response, And so from the unaffected, we go on gradually to this kind of a stage, from incipient TB to subclinical TB, and finally TB disease. And therefore, we have to understand where this patient is lying in the spectrum when we have to treat such a patient. So it is important for us to understand how to diagnose these various stages, so that we can actually pinpoint what the patient is suffering from and what kind of investigation and intervention the patient needs. So that is very, very important.
Hello, Anu, sorry, I forgot I'm logged in.
Sorry. Oh, sorry. Okay. So then this is now, the spectrum is absolutely guided by the pathogenicity of the organism and the status of the immune system. We are very much aware of the immune system thanks to COVID now. We were doubting it in case of tuberculosis earlier on. People used to say yes or no to it. But after COVID, we have all understood that immune system carries a lot of weight, especially in chronic infections like tuberculosis. It is the modulation of the immune system which actually defines where the patient is in this stages or in the response to the disease. So how do we go about diagnosing it? Because we have to now understand how to clear this enigma. So there are three kinds of tests which we have now come up to. One is the molecular testing, then the microbiological confirmation, and there are other tests as well. So molecular testing is now becoming the mainstay of diagnosis for something like genital tuberculosis, wherein you have GeneXpert, TrueNat, and line probe assay, etc. We will be talking about them in little detail. Microbiological confirmation, you all know, direct microscopy, AFB, you can see on Zeal-Nielsen stain, you can see the AFB, the bacterium itself, or you do a culture and you do drug sensitivity testing. We will be talking about that as well. And of course, in the gynae segment, we have histopathology, which is very, very important, where you're looking for granulomas in the endometrial biopsy specimen, or you look at the fluid from the pouch of Douglas, as I stated, radiology and ultrasound. So confirmatory tests, therefore, for diagnosing tuberculosis are microscopy, GeneXpert, TrueNat, MTB-RIF, line probe assay, solid culture, and liquid culture. We will define each of them and I will tell you which ones are the ones that you have to select in order to actually diagnose tuberculosis in your clinics. So microscopy actually is very good because the turnover time is the same day, and sensitivity and specificity you can see over here. But GeneXpert has become very important for us also in gynae, and therefore you have to understand that you must send the sample for GeneXpert MTB, because it also tests the sensitivity or resistance to rifampicin and isoniazid. Therefore, it is important to conduct this test. 98% specific and 85% sensitive. So also you can see over here. So these tests have become very, very important for us, especially because they have a very quick turnaround time, and therefore basically the results come in fast and you don't lose enough time. You don't lose time to diagnose the condition. Now, the key molecular diagnostic tests, as I outlined over there, are the Expert MTB or RAF or Expert Ultra. Now, remember, all these tests that I'm mentioning over here are recommended also either by our own department in India as well as the WHO. So these tests are something that you must know and you must send your samples for. So all of us know that there is a cartridge-based automatic NAT, which is nucleic amplification of the tests, of the nucleic acid amplification, which
Nucleic acid
amplification, yes, which detects DNA for MTB complex and resistance to rifampicin in under 2 hours. So this is very, very important, because basically this test gives us the kind of TB that the patient may be suffering from. Is it normal, or is it a drug-resistant tuberculosis on our hand? So then we also have TrueNat, MTB or MTB Plus, which is a chip-based real-time PCR assay that is portable. And interestingly, this is an Indian product which has been developed by a company in India, and it is actually recommended also by WHO. Then the TB LAMP, very simple rapid test, where again isothermal amplification is done using a lamp. It is actually very suitable for low-level laboratories because it doesn't even require any air conditioning. So line probe assays, again, rapid tests, whole genome sequence is something which is coming up. And this is probably one of the most advanced molecular analyses which are going to actually tell us what kind of a tuberculosis this is, because we all know that there are many subtypes and many kinds of organisms have developed as a result of multiplying rapidly, and also because of the drug resistance. So therefore, in order to understand what exactly is happening in the body of the woman, we need to know whole genome sequencing of this patient, and that is something which is coming up. This is the TrueNat machine that I was talking to you about. This has been developed by this diagnostics, which is in Goa in India, and it is a portable battery-operated real-time micro PCR test, which has been WHO recommended. So the TrueNat has various features. It actually targets the NRDB gene with a limit of detection of 100 CFU per ml. So basically the detection is also at very low levels. TrueNat MTB Plus, on the other hand, is an improved version using two targets, that is the IS6110, which is the one which most labs are using for PCR as well, and IS1081, which has been used by some of our labs across India for higher sensitivity. And this is actually testing for 30 CFU per ml in specially possivacillary sample. So somewhere I think this may help us more than the other NAT tests that we have. Again, there is another version of it wherein you can test for the resistance to rifampicin also. So all these various variations of TrueNat are available, and they are actually recommended by WHO for using in our patients as well. What about indirect evidence now, which is the mainstay in gynae practice? We are actually visualizing the lesions, and we are actually looking for these when we are trying to diagnose tuberculosis. We are all aware of these various X-ray pictures that I have shown over here. So they are actually pathognomonic of tuberculosis. We all know that. And therefore, if you have an HSG like this, you should be suspicious of it. Ultrasound findings also are now very, we all know them very well, and we are quite familiar with them. And irregular broken endometrium, which is not conforming to any stage of the menstrual cycle, could tell us that there are some adhesions over there, or there is breaking of the endometrium. There could be calcification within the endometrium and some minimal amount of fluid over there, and old calcification also could be found. So adhesions, adnexal mass, hydrosalpinx, fluid in the POD, etc., all of them, plus of course probe tenderness, these are actually suggestive of some kind of an inflammation over there. And most common inflammation is tuberculosis, so we attribute it to tuberculosis. How about endoscopic lesions? I think most of us who are doing laparoscopies and hysteroscopies have seen these lesions in our patients in India. This is a very, very advanced miliary kind of a tuberculosis, as you can see, and there's a lot of fluid in the POD. This is a moth-eaten uterus seen on hysteroscopic imaging, and this is what it looked like later on after ATT was given to it, slightly better, but still needed more ATT. So it defines how long you need to treat the patient once you have this kind of a picture, because you can do a relook laparoscopy or a relook hysteroscopy to see whether you have really actually cured it or not. And then you have the third problem, that is the immune modulation. Now, this is something that I have been talking about for a very, very long time, since 2000, maybe 4, or even this one came out even earlier. We were actually suggesting that the tuberculosis bacillus is actually modulating the immune system to an extent to make it favorable to its survival, and therefore it causes infertility and recurrent pregnancy loss both. So these were some of the thoughts that I presented, but later on it has taken a very long time for everyone to accept it. We now have the CD138 also present with us, which actually talks about plasma cells surrounding the granulomas in cases of tuberculosis, but as such, it could be present in non-specific endometritis as well. And therefore, if you find persistent chronic endometritis, which you have treated with antibiotics, and it is not going, do a repeat biopsy. And when you find it again over there, that it is probably tuberculosis that you're missing. In our patients, in our series of recurrent implantation failure and recurrent pregnancy loss, we found that 26% of the patients of infertility were suffering from chronic endometritis, and out of those, about 20% actually were those of tuberculosis. How about, and then look at this beautiful, beautiful paper from Dr. B.N. Chakravarti's lab. Again, it showed all the markers over there, all the markers in the endometrium are disrupted in cases of tuberculosis, and it gives rise to such a bizarre picture over there in the endometrium, and therefore it is not conducive to a implantation. So also on electron microscopic examination in the same study, they also found that the pinnaboards are also disrupted and totally bizarre, thereby causing a totally non or an unfavorable kind of an endometrium for implantation. So this is a beautiful study conducted in Dr. Chakravarti's unit with the IIT Kharagpur. So therefore, what bothers us is essentially, where is the bacterium in latent tuberculosis? When we don't have any symptoms, the patient is only coming clinically with infertility, nothing else. Where is the bacterium? What is the pathological or immunological factors of these patients? Can we measure MTB products and correlate these with the spectrum of tuberculosis? And what are the correlates of protection? What is the role of T cells and B cells in this spectrum of latent tuberculosis? And what is the breaking point of reactivation and dissemination? This is very important. A patient may have a latent tuberculosis for years, causing no problems except infertility, but then suddenly she gets reactivated. So what is it that causes it? So we need to understand it. And these could be addressed by a comprehensive study of the immunological and cellular markers. This paper, beautiful paper, which appeared in 2010, actually defines what is happening to TB in all these stages, which I had showed you earlier. What is happening to the markers? What is happening to the cytokines within the tissue? And remember that all the tissues are different. If you have scarring in the pulmonary, in the apex of the lung, that part is sealed, and therefore the TB doesn't spread, and that is all. We are happy that it has kind of been contained. However, in our reproductive system, if the tube is actually fibrosed, then it is the end of the story for her, because she's not going to conceive. So what is the function of the organ? What is the function of the tissue where the bacterium is present, and how does it act over there is very, very important. And so for us as fertility specialists, we have to look at it from a different perspective. And so what is it? What causes it? What changes from latent to active in our specialty? What are the risk factors, host resistance and inflammation, compromised immunity due to non-communicable diseases like diabetes, type 2 and pregnancy, characteristics of immune activation and inflammation which may be present in the person herself, genetics, HIV co-infection, and any therapy using TNF-alpha. For instance, for the rheumatoid arthritis, for uveitis, if they are on TNF-alpha blocking drugs, then there is a chance that the TB is going to be activated. What are the pathogen factors? Pathogen species and load, degree of pathogen replication, type of pathology and spread of lesions. Basically, yes, even this is going to affect the way the host is going to react. So that is why when you have a patient who is already infected with HIV, there is every chance that the TB is also going to get activated. But most importantly for us, when we are doing follicular stimulation, when we are doing a pricking, also at that time, the TB can be activated in patients where it is lying latent. But again, it will depend upon the pathogen species, it will depend on the load and so many other factors. But yes, there are chances where even IVF can stimulate it. So this spectrum of response is definitely most important for us. And therefore, we have to come back to IGRA. IGRA is basically these, you all know that these are T cell responses, which we are now using instead of the TSTs, which is the Montu test. We are now using these tests, and out of them, this T-spot test is very, very, it has been around since 2010, and it is a very good test because it tells you which cytokine is active and which one is suppressed. So in the latent variety, in the latent tuberculosis, it is the IL-2 which is high, and the TNF-alpha is depressed. And you do this test and you find that the IL1, IL2 is high, but it is showing a red spot over here, then it means the patient is having latent tuberculosis. However, if the TNF alpha is upregulated, then it is a sign that this patient is now having active tuberculosis, and therefore that the spot then turns green. But if you have a mixture, say here, then it means that there is a dual sequencing over here, similarly over here, depending upon the grade of the red and the green. So if it is more towards the red, it is latent. If it is more towards the green, it is more active. So if you have a mixture, it will tell you that it is now moving from latent to active tuberculosis, and you have to take a little more action in this patient. So this is a useful test, which is also recommended by WHO. And then there is a huge range of biomarkers which are now being developed to understand each stage, the innate phase, the adaptive phase, the quiescent phase, the replicating phase. And you can see over here in this paper, which is also not very old, but yes, in May 2011, where biomarkers of tuberculosis have been targeted, and you are looking at them to see what stage the patient is in. And these are very important from our point of view. You understand that they have been very relevant for HIV because we are looking at the Th4, Th8 response in those patients. Similarly, in TB also, we need to have these and try to understand where we are at the moment. So the current drawback, of course, is that none of the diagnostic assays are sufficiently sensitive or specific to assign the patient to a particular place in the spectrum. And this is, of course, a research priority where we need to understand whether to treat this patient or not. In all these seminars that I keep on talking to all of you, the question that you all ask me is, how do we know whether this patient is having latent tuberculosis or active tuberculosis? Yes, that is the million-dollar question, and that is what I'm trying to address today. We are inching towards it, but yes, we haven't reached it completely. So this paper came out from Dr. Mahajan, Nalini Mahajan's unit, a couple of years ago in 2016, where she strongly advocated the use of IGRA, EB for DNA, PCR, and Cox culture, all of them together to actually understand the spectrum, to understand where the patient is on the spectrum of the disease. And this is actually now being taken up greatly by the new National Tuberculosis Elimination Program 2020. Please tell me when my time finishes. I don't have any access to that. Please indicate to me. So
there's a lot of time, ma'am.
Okay. So now.
Yes, Sonia ma'am, I think you take your time, ma'am, because
Okay.
Lot of information. Yes, ma'am.
So in the revised what we had was the revised National Tuberculosis Control Program, because we are actually a part of the WHO program of elimination tuberculosis. But then what happened is in 2006 there was the Stop TB strategy, and now of course it is Eliminate TB strategy. So therefore this has been renamed as the National Tuberculosis Elimination Program of 2020 now, which talks of these composite reference standards. And I will explain to you what is composite reference standard. Inclusion of gene expert and elimination of TB PCR, and elimination of category-based treatment. So therefore, basically now, come what may, whether it is latent, whether it is active, you have to treat it. That is the program now, because we need to eliminate it because of the rising incidence of resistant tuberculosis, and that because TB is just not getting eradicated. So this is what is happening now in TB. And under this program, what is happening is the key activities are active tuberculosis case finding, newer and shorter treatment regimens, private sector engagement, very important, financial and nutritional support to TB patients under the Nikshay Poshan Yojana, IT-enabled Prevent TB India's app, surveillance and awareness drive. You will be surprised to see how well they have developed this IT-enabled program. But most importantly for us as gynecologists, any form of TB, if detected, is notifiable. Whether it is latent, whether it is active, doesn't matter. You have to notify it. So therefore, the question of what is it, whether we should treat it or not, is no longer remaining. We have to treat it. So what is a combined reference standard? What do we say? What do we mean by it? Because there is no single test to rule out extrapulmonary tuberculosis, certain diagnostic criteria have been suggested by WHO, and the use of a combined reference standard instead of culture is recommended to improve our case detection. So what does it say? What does WHO say? one culture positive specimen, positive histology, or a strong clinical evidence consistent with active tuberculosis, extrapulmonary tuberculosis. So a combined reference standard could include a smear, culture, histopathology, cytology, biochemical analysis, or a response to treatment at 6 months, adenosine diaminase levels in the POD or any fluid that you collect, or radiological findings. So such a huge difference, huge range they have suggested. However, they have not suggested ultrasound because radiology, in the radiology, it is X-ray plus ultrasound, but not separately as such, whereas for us, ultrasound is one of the most important features. So out of any of these two should be positive in order to say that this is positive for tuberculosis. Now, again, the standardization of these criteria, again, is a slightly big challenge for us. But however, this has helped us to diagnose more and more cases. So what do we now have? These are the tests, huge range we have: AFB microscopy, histopathology, microbacterial culture. Like I said, the usual ones, the LJ culture, BACTEC Midget 960, IGRA and TST, uniplex PCR or multiplex PCR, cartridge-based nucleic acid amplification. So it makes us all confused. We are so confused as to what we should be using and what we should not be using. However, these clinical tests, I would suggest, and we all know, we all are doing it, these are definitely important for us because we cannot get many positives on these various biochemical or the molecular tests that we have. So we do have to actually depend upon our clinical tests also, but they form a part of our composite standards. That is what is important. So what are the tests out of this whole range which actually become positive in active infection only? These are the three tests that you would have to, if they are positive, you should consider that this patient may be having an active infection. And which are the tests which come positive in both active and latent? These are the tests which become positive both in active and latent tuberculosis. That is why we said initially that PCR should not be used as a diagnostic molecule because it may be just latent. But now, since we are targeting latent infection also, things have changed. So therefore now, according to the National TB Elimination Program, the tests which are diagnostic for tuberculosis are microscopy, culture, and expert MTB, rifampicin RIF assay, that is the expert assay, gene expert in other words. WHO recommends the following tests: expert MTB RIF, expert MTB RIF ultra, loop-mediated isothermal amplification, and TrueNAT MTB and MTB plus tests from India. So these are the tests which are recommended by WHO, and of course they are nearly the same, this or this. What is important for us to understand is that any test that you send out of these molecular testing should also test for rifampicin sensitivity. One of the tests must be for rifampicin sensitivity because we are having too many of these resistant tuberculosis cases. Here is a workflow, standard treatment workflow for the management of female genital tuberculosis. This was brought out jointly by ICMR and the Ministry of Health and the TB control program in 2022. When to suspect, what do you see in clinical examination, and what are the specific investigations that you will do for female genital tuberculosis. You can take a screenshot of this, or you can go to the website and you will find this over there. And these are some of the findings which are suggestive of female genital tuberculosis. This is how you will take a stepwise decision on what to do: clinical history, physical examination, pelvic ultrasound, definite TB needing ATT, any of these positive, probable TB, and negative for TB. So I told you that you have to go by the definitions which have been given by the Government of India, and based on that you have to define what kind of TB your patient is suffering from. And then in the management, again, you treat the patient according to the National Tuberculosis Elimination Program. And follow-up also is very important because after 1 month, a clinical examination is suggested. After 3 months, again, clinical evaluation is suggested. But after 6 months, clinical evaluation and investigations, that means endometrial biopsy, hysterolaparoscopy, and ultrasound, if needed, these can be must be done in order to see whether the ATT has been effective or not. So therefore, this is how you will proceed according to what the government has now very well and very clearly ICMR has outlined. So again, if you take a algorithmic view, pelvic tuberculosis can be active or dormant, symptomatic, asymptomatic. They can come with these symptoms, a large range of symptoms which may make you suspect it, which may not. You can confirm the diagnosis when you have these. Similarly, in these cases where this is infertility and recurrent pregnancy loss and recurrent implantation failure on IVF are our most common patients, where again it is a chance discovery on investigations, but treat only if more than one test. Like I said to you, it has to be a composite testing now rather than just one test over there. This is a beautiful, elaborate algorithm which J.B. Sharma has outlined in one of his articles in 2020. Over here, again, he says the same thing. Any of these four, if they are positive, you have to treat definite TB. This is all definite TB, and you can start ATT. Start ATT if you find any of these positive. Similarly, if there is a PCR positive only, then it is a suspicion for MTB, and then you have to go further and try and do all these investigations in order to start ATT. You can just not start it on the basis of PCR. We are very clear on that now, and most of us are actually not using it as a rapid test for tuberculosis. Now, again, this article, again, this is from Indonesia, but it also tells us how to use a composite reference standard, which means that you are using more than one test, a kind of a battery of tests, which actually tells us whether this patient is suffering for tuberculosis or not. Ultrasound imaging and, of course, pathology. The molecular testing was what they did, and they found that all of them can, with a very good, they could find a very good correlation with all of them. They had a moderate agreement in the diagnosis, so they could see that there was a definite CSR TB patient in 6, probable in 10, possible in 21, and non-TB in 6 instead of doing just one test. So therefore, a systematic testing of 2 or 3 methods is much more important than doing just one. And this is just a little chart to tell you what is the cost of these tests. This was prepared by Manisha from Nova Chandigarh, and actually it is very useful to let you know what is the cost of these tests and what is the turnaround time of these tests, so that you can know how soon you can start treating your patient. Coming to the most important part of TB is notification. Now, please remember this, that failure to notify TB cases by qualified providers is considered misconduct under the MCI Code of Ethics. This is very important, and therefore, you have to know how to notify the patient, and you have to notify any patient that you are finding some kind of a problem which could possibly be TB. So what is the process? You have the Nishke portal, where this is a beautiful portal. Go onto the website and see, and you will find all the steps of notifying your patient over there. Then you have the TB Arogya Sathi app, where again it is a mobile application for reporting, and it is also meant for tracking the patients. Here, the Nikshay portal actually does a lot more than just notifying. It is tracing, it is giving medicines, doing everything. So direct reporting happens because of can happen because of physical forms which can be sent to the local health authorities, or a direct center reporting can also be done, because the laboratories are also mandated to report TB cases directly through a digital integration with the Nikshay portal. So the information that you have to send, it should include patient's personal details and contact information, the type of tuberculosis, the treatment initiation details. And the benefit of this is that it ensures the patient's free treatment, support, and care, and it also facilitates contact tracing to reduce further dissemination and transmission of the disease. So therefore, all of us, we must become much more aware of this. I know that many of us would be actually notifying our patients, but there may be many who may not know that they have to notify this in such a manner, and therefore give the benefit also to the patient. Patient receives money as well for nourishment, and actually gets, and even the person who is reporting gets some amount of money. So if your nurse is reporting it, she will get the money which is to be given to any person who is notifying the patient. So it is a digital platform, Nikshay. and it is for patient management. It has a Nikshay Poshan Yojana, where there is 1,000 monthly note given to the TB patients for nutritional support. Actually, milk is something that they are giving to all of them. And Nikshay Mitra initiative is a community-based program under which these organizations actually adopt the TB patients. So in a way, the government is trying its best to actually give multiple support to these patients. Now, I know that since most of us are practicing in metros and cities, our patients, one, of course, they are infertility patients, so they never break the rules. They will take their medicines. They will do nothing wrong. But there are patients in the rural belt also, and many of us are serving there as well, where the patients are below the poverty line and they cannot afford this kind of expensive treatment for 6 months or maybe even a year, where you will have to support them. So notification, treatment tracking, financial support, and the community involvement of by Nikshay is actually helping our patients to tide through this problem of tuberculosis. So now, composite reference standard of tuberculosis. Positive AFB culture from endometrial biopsy or tissue, demonstration of acid-fast bacilli on endometrial or tissue biopsy, histopathology evidence of epithelioid granuloma, and definitive findings of FGTB on laparoscopy like tubercle, etc. So positive gene expert test on endometrial lesion or biopsy lesion, and probable findings on FGTB on laparoscopy like encysted ascites, dense pelvic adhesions, etc. These are all suggestive of genital tuberculosis, and if you have these positive, you can put your patient on ATT. Alone TB PCR, I'm stressing again, is not going to help. So our stance is now, the national program is that we have to eliminate TB by 2030, aggressively treat these patients which you have diagnosed as active TB, investigate the close contacts and high-risk individuals for latent TB, and recommend tests for detection of infection is IGRA. In case of suspicion and positive IGRA, give a preventive treatment. So this is the guideline for how you should be treating TB now. Now, unfortunately and sadly, FGTB does not fall in the group of latent tuberculosis where we are trying to look at the contacts. But since we have a large patient pool coming to us, we will do exactly what is written over here. So the advantage of this comprehensive testing actually is because empirical treatment is avoided, and the moral and family pressure related to a carrier of a transmissible disease is also avoided. Financial burden on the patient and state is avoided. Drugs used for ATT have serious side effects, and therefore, if you're unnecessarily giving it, it's wrong. Indiscriminate use of ATT can lead to drug resistance and serious consequences, which were always we were fearful of that. As gynecologists, we were saying, should we treat latent disease and cause drug resistance? That was the big question in front of us. So all that can be avoided if you're doing comprehensive testing for these patients. So what are the drug regimes? Is there a change in the drug regime? There is no change in the drug regime. Only thing is that DOTS, which we were very seldomly using in gynae practice and infertility practice, is now out. Patient has to take the drugs seriously and every day, and the government sees to it, or the center sees to it, that the drug is actually taken by the patient or not. So in drug susceptible TB, the usual regime is there: 2 months of these 4 drugs and 4 months of 3 drugs. That is what we have learned always, and that is what is given. Now, monotherapy or poly-DR therapy in polydrug resistant TB, in those patients, again, you have to give 6 months of levofloxacin along with these. This is one of the regimens. And then in MDR and rifampicin resistant and XDR TB, short oral BDQ containing regime. Here again, 4 to 6 months of BDQ plus 6 months of 1, 2, 3, 4, 5, 6. 6 drugs, 6 months of 6 drugs, and 4 to 6 months of, again, BDQ. All these drugs are to be given if the patient is having rifampicin resistance. Mind you, I have recently had one in endometrial biopsy. She was found to be rifampicin resistant. The this was the second time that TB was, she had already taken 6 months of ATT somewhere for pulmonary tuberculosis. And when we detected it in 6 weeks, she came out positive on culture, resistant to rifampicin, and she was I referred her to the physician, and he did put her not on all these drugs, but of course on levofloxacin and clindamycin on all these drugs. So longer oral BDQ also containing regimes are there for 18 to 20 months also. And then TB infection, the latent tuberculosis, what do you do for them? TB preventive treatment is given 6 months of daily INH monotherapy, or 3 months of HP. That means 3 months weekly dose of HP, that is 12 months dose, or only levofloxacin for 6 months. This is easy because patient also doesn't have too many side effects. And then 4 months regime also is there, where you give daily rifampicin in the context of these patients. But we are talking of our own infertility patient, where we can also give 4 months daily of rifampicin to these patients for preventing active infection. So INH monotherapy as well as rifampicin monotherapy can be given to prevent active infection in patients who are suffering from latent tuberculosis. So preventive treatment, I had just mentioned it over there. There are various regimens which have been practiced. Rifampicin for 4 months or 6 months of isoniazid and 3 months of rifampicin and isoniazid together. There again, a multicentric trial showed daily rifampicin for 4 months compared to a 9-month regimen of isoniazid, and a once a weekly regimen of rifampicin has a similar efficacy as 9 months regimen of isoniazid. So basically now we are shortening the treatment in some way or the other by giving these short treatments or ultra short regimen, also 1 month of daily isoniazid and rifampicin 300 to 600 milligram, which was nearly similar to 9 months of isoniazid. So basically all these preventive treatments have been suggested for latent tuberculosis. If you have a patient where you are really thinking that she has latent only, then you can put them on any of these kind of treatments also. Now then, coming to fertility, indications for ART, all the factors, any factor can be present in a tubercular patient, and therefore all these are indications for ART in such patients. Patient may have any of these factors. Even in the male, you may have severe male factor indicated by OATS, chronic prostatitis and epididymitis, obstructive azoospermia and azoospermia also. Basically, these are all indications for ART, and you all know that these patients have a poor ovarian reserve with a poor response. They require more gonadotrophins, poor quality oocytes, poor quality embryos, poor endometrium, and a low implantation and pregnancy rate. But as you can see over here, the eggs, some of the eggs are beautiful, some of the embryos are also beautiful, but you will find very bad eggs and embryos in these patients also, as also a bad endometrium. So you really have to struggle with your patients of endometrial tuberculosis, but of course, genital tuberculosis. But if the patient has not had severe oophorytus, then you may get away with good eggs. So some of the earlier reports of genital tuberculosis, as you can see in the literature, these are all old before 2016, as I was discussing with you. But you can see over here that the number of patients that they saw were very few. In fact, the ones that we had at the end was 120, which is much more now in the recent reports. But as you can see over here, the pregnancy rate was really poor if the patient is detected late. If it is detected early, then the pregnancy rate improves. So these are also earlier reports of our own, some of our own doctors who have actually looked at tuberculosis rather closely. And you can see over here, all of them, these are old reports, but you will find many more reports in the literature now. And basically, again, as I said to you, if the tuberculosis is detected early by these new molecular methods, the success rate is much better. But if the damage is already done, pregnancy rate falls to about 15 to 16% only. So to sum up, clinically, we can only suspect it and confirm if there are gross changes. But tests are many, but gold standard is in demonstrating the bacillus is few. But GeneXpert and NAT may help, but with other signs and symptoms. Endoscopy complements ART when we have to treat infertility in these patients. And pregnancy is high risk and needs careful monitoring. ATT is safe and must be continued in these patients if they are diagnosed with TB. And new treatment guidelines of the Government of India have to be followed. So with that, I thank you very much for being here with me, and I hope I have been able to solve some part of this enigma. Thank you very much. Thank you very much.
Thank you very much. I request Shobha Gudi madam to say something.
Oh, of course, of course. What is there to say? Hello, ma'am. Good evening. Sorry, I was a few minutes late in joining. I'm sorry. And yeah, that was fantastic. Actually, you gave a overview and also the insight into solving some of the puzzles which come up in tuberculosis. Of course, diagnosis is the most challenging is the diagnosis, because treatment, the drugs will do their job, whatever they can do. But the first part, diagnosis, is the most challenging part, especially for FGTB.
Yes.
Ma'am, I think if there are some questions, but I must just say that listening to you, it's such a classroom atmosphere, and so much learning happens, and we are really
Well,
very
thank
inspired.
you. Thank you.
By
Thank you.
very inspired.
Thank
Thank you, ma'am.
Thank
A
you.
lot of insight. I
Thank
just wanted to ask you that once we pick up on hysteroscopy and endometrial, disease, and we put them on, in your experience, how much of reversal happens, and what has been your experience with these women with endometrial tuberculosis?
See, I mean, I am very confident when I see this happen. I see endometrial lesions and we find tuberculosis. What is my observation is that it takes 1.5 years for the whole syndrome to normalize. One thing is the infection, and the second is inflammation. So the infection is treated by ATT. Once that subsides, it takes another 1.5 years for the inflammation to settle down.
Correct.
So therefore, if you are in a hurry to you cut the adhesions and you keep on cutting them, they'll keep on coming back again and again. But if you wait for some time, then they will disappear themselves if they have to. In case they don't, then she can never benefit from what you have. I mean, she's not going to benefit. You will definitely have to do some operative treatment. I found this even in frozen pelvises, where the patient has come with frozen pelvis. You're seeing tuberculosis over there. You're diagnosing it. In those days, it was only PCR we were doing. And after that, you tell the patient, well, look, nothing is going to help you. We'll try IVF. I don't even know whether that is going to help you or not. But she comes back pregnant after 1.5 years, spontaneous pregnancy, with blocked tubes, with everything. So it takes the inflammation, you have to give the patient time, at least 1.5 to 2 years. If she has to conceive during that time, she can. Otherwise, you have to do intervention for her, maybe what you want to.
So the waiting period becomes up to 18 months to
18 months.
24 months.
Even after giving a full course of ATT.
It's such a powerful message, ma'am, that
observation.
non-intervention and patience will help.
Yeah.
And the residual scarring which you see, is it very common, ma'am, the scarring, or most of them heal properly?
Yes, of course. Most of it heals, but yes, scarring is there. You can't deny it. You have it everywhere in tuberculosis.
That is what. Tissue damage will be there. There is loss of tissue.
See these patients with calcification in the uterus, you see it everywhere. Those patients definitely we will find it very hard to actually make them
Very
pregnant.
hard.
They are the ones who may need
because
surrogacy
I have,
at the end, they may
I
go.
have, I have heard some experts say that the moment you see endometrial calcification, you should tell them about alternatives and treat them, but tell them. Is that true, ma'am? Do you think?
So, again, I can't swear by that, but yes, what you are saying is correct. Majority of them will end up with nothing, but some patients still with calcification will conceive. The only problem is continuing that pregnancy. It's not conceiving. It's
Correct.
continuing of pregnancy, the recurrent losses that they keep having.
Yes,
And but very interesting observation also is that when they have this minimal damage and they keep on conceiving, the fetal heart is present at 7.2 weeks ultrasound, and on 7.3 weeks it disappears. Try it. You will find it in your patient. This is my observation. They perfect flows, everything is normal, growth is normal. She comes and you do an ultrasound, fetal heart is absolutely fine. 7.4 weeks gone. Suddenly, I do not know what is it and how to explain it, but in these patients, you really have to be careful when the patient approaches that period, because that is where they are going to go. That is where they actually have a maximum number of abortions. But of course,
almost
yes,
behaves like a genetic loss, but in fact, it is
absolutely,
anatomical.
absolutely,
Yes, something
somewhere,
like
somewhere.
that.
And another thing is, that is my observation I would like to share with all of you. Anybody can correct me also. But there is a very thick adhesion band which is formed at the fundus in many of these patients on hysteroscopy, which is mistaken for a septum. And you cut the septum. And then the patient comes after some time, she goes to another doctor. She says, oh, उसने तो ठीक से septum काटा ही नहीं, there is a septum, and she cuts the septum. Then she goes to, so these people have multiple septal resections, and ultimately, the cavity becomes all full of adhesions and nothing happens. These are tubercular adhesions which are so thick that they appear like septum. So that is something that you people have to, think of and see for yourself if you find these things. These are anomalies that I have found in my practice. I haven't reported them, but I'm sure I should have. Just like JB is reporting so many unusual things, in patients of tuberculosis on laparoscopy. He's finding those, what is that? Something Curtis syndrome with where all the adhesions are stuck.
Fitzhugh-Curtis.
In the liver, perihepatic.
Fitzhugh-Curtis syndrome,
yes.
Correct.
Perihepatic, adhesions. So these things we never knew they could be because of tuberculosis. But that means, all these funny things is something that you have to be careful about.
It's a fantastic presentation.
Can I ask
Thank
one
you.
question?
Yes, please. Over to you.
Thank you, ma'am. Normally in infertility especially, there's a thin endometrium patient comes and we do a hysteroscopy. There are adhesions and all tests for tuberculosis comes positive. We do a relook hysteroscopy, again adhesions will form. So should we treat this patient for tuberculosis? Test will not come positive. They will present with recurrent adhesions in the hysteroscopy.
That's exactly what was I saying just now, Santosh? You will find that there is a very thick adhesion. It is actually an adhesion, yet you are mistaking it for a septum all the time. But it's actually an adhesion which is there. So these are the patients of latent tuberculosis which you have not been able to pick up. So and I would definitely put them on ATT empirically on strong clinical suspicion. Strong, that is one of the indications also given in the guidelines, where you have strong clinical suspicion and you're thinking of tuberculosis, but none of the tests is coming positive except that PCR. PCR alone is not to be considered, but strong clinical suspicion, on the basis of that, you can give empirical treatment and see. That is what is also recommended in that guideline. So you can do that if you want to, but if you're not convinced, don't put her on ATT. Now we have so many things. Yeah.
One more question I want to ask, ma'am, regarding the
Santosh, I just want to add here.
Yeah,
I don't think we have any Sonia Malik, madam. Really wonderful talk. We really enjoyed listening to you and seeing you as well. I think there's no denial to Santosh's questions of adding a ATT of your answer. I think that's really taken well. I am opening a Pandora box here. I think PRP is an answer to the Asherman's, for the recurrence, especially when it is so dense and this thing. I would definitely say PRP is an answer.
Alone,
probably after treating tuberculosis.
Yes, of course. That's why I said ATT is definitely a treatment modality. Along with that, this is something that we should be considering.
We should. Yeah, PRP.
Ma'am, one more you have mentioned about IGRA test and T-spot test. Are they available and what name they are available?
It is available under the name T-spot only. IGRA is available. IGRA is now recommended by the government of India also. Earlier, a couple of years ago, they said that in India, tuberculosis is rampant, so everybody will have a positive IGRA. Therefore, IGRA was banned. Any of these tests which were testing for these cytokines and etc. were banned. And antibodies also. You remember we used to do IgM, IgA.
Yes, ma'am.
Tuberculosis, that was all bad because the government said that we are going to find lots of tuberculosis and we are not equipped for it. But now, because it is a tuberculosis elimination program, they have allowed to treat latent tuberculosis also. Hence, you have to do the IGRA also in these patients in order to know whether I get it done in my patients where I'm suspecting it and I'm not finding anything much. मैं भिजवा देती हूँ IGRA, because again we don't know whether it is latent or active tuberculosis. So in order to decide if the IGRA is also positive, then definitely this patient is having tuberculosis. So that is how. But I would also like to tell you, I mean, I have been using the Agilus lab. It's not anything, I'm not no favoritism or anything, but the Agilus lab recently, I do not know how they have modified their technique or what they have done, but recently we are getting a lot of positive patients on culture. 6 weeks culture, 4 weeks culture, we are getting TB positive. So, I mean, it is definitely indicated to do a culture testing also for these patients. Just don't send you have to send a culture, gene expert and culture, both, so that, you don't miss out on these slow growing bacteria. That is very important.
Hello, ma'am. Can I ask a question?
Yes, please. Yes, please.
Ma'am, there is a clinical suspicion, but none of the tests come positive. Can we still start ATT, ma'am?
See, again, although they are saying that you should not do it, but in the pulmonary tuberculosis area where they don't find it and patient is coming with fever only, fever of undetermined origin, PUO, there the clinicians are putting patients on ATT, and that is recommended by the government. So why this difference between extrapulmonary and pulmonary, we can't say, we don't know. But having said that, if you do want to put your patient on ATT because of clinical suspicion, you should take it in writing from the patient that I have explained everything to her and I've told you that this is an empirical treatment, and if you agree, I will put you on it. If she signs the consent, please go ahead and do it. Because otherwise...
And we have to notify too.
We have to notify, yes.
Correct. We have to notify even suspicion, and we are starting it. That is one thing which I wanted to take a lead and kind of have some discussion on our data, ma'am. Do we have good Indian data today? Do you feel, or is there paucity of publication? Why are we in the same place? I mean, we have more quantum of disease, so we should be the best in the world in this, right?
We are. Go and see the papers on PubMed. The maximum papers are from India.
Are from India.
That is why tuberculosis has become a global problem. Female genital tuberculosis has become a global problem. Nobody knew it, but now everybody recognizes it. And getting papers even from China, which of course to beat everybody, but still, the only problem, our papers are a lot. We have many publications on all aspects. Only thing is that the number of patients that we are talking about is not much. Somebody will talk of 100 patients, somebody will talk of 1,000 patients, but not more than that. Not like a 5,000, 6,000, big, huge number. It's not like that. That is why maybe, we have not been able. And you're a great one for registry, Shubha. I think you will have to start a registry for this also. Do you think so?
Correct. Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. That is what I wanted to know, whether something like a multicentric effort, a pooled data effort, or a registry, something like that. We can start nationally, and
now we are in a position to start.
There is so much of expertise now.
Now we are in a position to start it because we are very clear on the guidelines and on the tests that we have to conduct. So we can do it. Earlier it was only PCR.
Then we must start.
Everybody was actually doubting PCR to such a large extent. It is only with JB Sharma's insistence that this PCR is still in the guidelines. Otherwise, they were actually, the Cochrane people were removing it from there. They said this evidence is not enough. We cannot keep it as tests for tuberculosis. It is only he who was insisting that we must keep it because tomorrow there will be evidence and we will regret it. It's good because basically it is a test now. TB-NAT is nothing but PCR only. It is more composite, but it is PCR. So therefore we are benefited. Like that. So I think we are on a good ground and we should be able to do something like that.
Yes, ma'am. There is so much of expertise today, and it was so heartening to see you bring in papers from so many others, even your very junior colleagues, and telling us about the publications. That is so kind of, inclusive and so good. I'm really remembering B.N. Chakravarti sir so much because He was the one who did a lot of work on this,
Very,
and
very
wonderful.
He was
Really miss his. Okay.
anyway.
Madam,
Yeah.
Yes,
So
yes,
Madam,
yeah,
may I
please,
ask
please. Yeah, please.
Madam,
Yeah.
given an option, which tissue sample is better or fluid blood sample is
No,
better?
blood is not to be sent. Blood is not. Please remember, menstrual blood is out.
No, not menstrual blood. Blood.
Then blood for what? Blood for IGRA, yes.
Any gene expert and all tissues, endometrial sample is better or blood sample is better?
Endometrial sample is to be sent for gene expert, but blood sample can be done for IGRA. You're not doing a gene expert from there. You're not doing a blood culture. Not from there. You cannot. There is no tissue. There is no bacteria over there which is going to come up. It's only in the reproductive system, na. So it is the endometrial biopsy sample only that you have to send. Again, menstrual blood sample is not to be sent because that has got so many of the amplification suffers. It has got so many. I don't remember what is it called. They don't allow them to get amplified. The bacteria or the segment of the bacteria. So therefore, that is not to be sent. Only the tissue has to be sent for
So
testing.
what will be the exact protocol when if I found a patient positive on laparoscopy, then
Yes.
I should go for gene expert or what will
Yes,
be
of
the
course.
exact
Yes, you have to go for gene expert. Our composite reference standard in my clinic, in my center, is to do an endometrial biopsy wherein we send a histopathology, we send a PCR, this gene expert, and then we send a tissue culture for this thing for MTB. And we also, what is the fourth one? That we send 4 tests. So fourth one is for chronic endometritis, CD130. So we send all these.
CD132.
Yeah, so we send all these 4 tests in order to determine what kind of inflammation it is. That's it.
The tissue culture, whatever you are sending, will be 2 types of culture you told, solid and liquid. So
We are sending the rapid cultures, na? The backtech cultures, only that. Or the MIT, what is it? Midget 90. That is the one which is recommended by the government, no? So these liquid cultures are the ones which are rapid, not the solid culture.
most of the times, even we suspect the results come negative, madam.
Hanji, sorry?
Most of the times the lab reports come negative.
Of course,
Even we suspect.
Of course. That is the biggest problem for all of us. Anyway,
That is the biggest
Dr.
problem.
Sonia,
Which lab
one
you
question,
suggested?
ma'am.
Aglas.
Dr. Sonia, one question.
Yes.
Okay, symptomatically patient is fine, but we do a diagnostic laparoscopy. The findings are very much like 95% we know it's tuberculosis.
Yeah.
And all the tests come negative, as you were mentioning. Back tag, this. Is there a role for treatment of ATT in such cases?
Oh, no. She could be something else. She could be just a very severe chlamydial infection. No, don't put her on ATT unless you are saying she's asymptomatic. There is no symptom also. And plus she's got nothing. So she may be having some other infection, not tuberculosis. Unless you are certain that she is tubercular on some test or the other, then only you should put her. Otherwise, don't put her on ATT. Don't put her on.
So that.
But suppose Anuradha,
on
just
empirical therapy. That's my question. Lot of people, except in the outer areas, like they do a laparoscopy, they have a suspicion, and the empirical ATT. I have seen people start, especially in Uttar Pradesh belt. Uttar Pradesh, which is is it correct? I mean, they do start empirical.
Again, they say that once we started, they get results because the patient becomes pregnant. That is also
that is what my friends also say, that patient conceived
that
after
is also
ATT.
true. That is also so. Therefore, it may have been a missed case of tuberculosis, but this patient will come into the diagnosis of presumptive tuberculosis. She's presumptive. She's not a confirmed tuberculosis. No, she's presumptive. And in the presumptive, they have written that if you have one test like a PCR and a strong clinical suspicion, or one of those findings in laparoscopy, something, then you can put the patient on presumptive diagnosis of tuberculosis. But
presumptive diagnosis.
As such, you should not unnecessarily, because there is so much of liver toxicity in these patients and so much of resistance also. There is one thing that I must tell all of you that you must be aware of also as gynecologists. Rifampicin has a very big correlation with estrogen. It acts on the P450 enzyme system, and therefore what it does, it negates the estrogen in the body. It decreases the estrogen. Hence, your contraceptive pill, which you are giving to the patient so that she doesn't get pregnant, doesn't have an effect and the patient can get pregnant. There are two papers which actually started this controversy.
Correct.
That
Yes.
the patient became pregnant when she was taking ATT because it is rifampicin is negating estrogen. It is completely taking it out of the body. So when you are giving rifampicin, be careful that you don't give estrogen along with it. So many times I see that patients are being treated for frozen embryo transfers. You are giving HRT treatment to them for making the endometrium, and therefore also on rifampicin. In those patients, you will find that the effect is the endometrium is not going to improve because the estrogen is not going to act over there. So be careful when you're giving them to these patients.
It's really
Yeah,
good
that is
information.
very
Anuradha's case, ma'am, what Anuradha told, if we say she has no symptom, but she is having infertility, isn't it? She is having, that is why you have done a laparoscopy.
Yeah.
So
She is infertile. There is
then
little
will
bit
that
on.
not be a ground for treatment? I mean, she's
Yeah, that's what.
infertility.
No, ma'am.
So many
That was my
additions.
question.
The
Again,
addition we
that
pick
is
up for biopsy does not yield the result. So
yeah, again, it will still be
it will
presumptive.
still be presumptive.
It will
And
be
whether the woman
demonstrated.
conceives because these drugs have a anti-inflammatory effect also.
There was an effect of immunomodulation also, ma'am. Rifampicin has some immunomodulation.
Anti-inflammatory on the endometrium also. So maybe.
People, surgeons, I was surprised to know this. One of the andrologists I spoke to is giving rifampicin for non-healing ulcers. Daptic ulcers or anything.
It has got a effect on chronic inflammation.
So
Yes, madam.
It's a very strong antibiotic, so we can give it. But the only problem is causing rifampicin resistance.
Resistance.
I think we should stop because the panel also has to happen.
Yes.
Okay.
Yeah, thank you, ma'am.
Yes. But this was really good. And I must really thank Shilpa for bringing me in as a chair, because it has been an absolute privilege to be a chairperson for Madam's talk. And I always look up to her as my guru, and really very blessed, ma'am, to have.
It's a mutual admiration society.
Oh, no, ma'am.
We all are. You scratch my back and I scratch yours.
No, ma'am. No. It is not like that. No. Thank you, ma'am. Thank you.
That back has to be really good to be scratched.
to be scratched. That I totally agree with Anuradha. But ma'am, you have one wonderful ability. You make even very junior person very comfortable.
Yes. Even I admire that quality. That's why I said that she quoted papers of everybody, be it senior or junior, and I loved that really. So thank you, ma'am, and I hope more publications will come. Shilpa, you have done very good by bringing in Madam for Kasuga. And I thank you,
ma'am. It is all Dr. Santosh's work.
Yeah,
It's
Santosh.
all,
Thank you very much, Santosh. Thank you.
Santosh is my
Thank you, ma'am. Thanks for coming, ma'am.
Thank you, Santosh.
Thank you, ma'am. It was really informative, useful for everyone who watched it. Thank you, ma'am.
Thank you, ma'am.
Hello, Santosh ma'am, may I proceed?
Yes, please. Hello.
Yes, Bhakti, you can.
Santosh, hi, we can hear you.
Yes.
Yeah.
Hi. Good evening to all the esteemed faculties, and once again, very warm welcome to you. And this is Bhakti Gaukar, and I am representing the medical team of Universal NutriScience. So yes, it is my privilege to be a part of this today's academic program, and on behalf of Universal NutriScience, it gives me a great pleasure to welcome our moderators. So our first moderators for this session is Dr. Santosh ma'am. So welcome, Santosh ma'am. So just a minute, I'll just share the CV of. Okay. So, Santosh ma'am is a clinical director and a senior consultant in reproductive medicine at Nova IVF Fertility, with more than 5 years of rich experience as a consultant in the reproductive medicine, with extensive involvement in the teaching and training. And ma'am has received several academic recognition, including the prestigious Dr. Asha Rao Award at ESA 2020 at 2013, and a second prize at the International Conference Cutting Edge 2011. Ma'am also actively involved in the leadership roles, and is an executive committee member of the BSOG and a former treasurer of the Karnataka Society of Assisted Reproduction. And our second wonderful moderator for today's session is Dr. Shilpa Harish, ma'am. Welcome, ma'am. Ma'am is a senior consultant, IVF specialist, obstetrician, and the gynecologist. And ma'am is currently associated with the Sattam Fertility and IVF Center, Rajashri Granthiam Foundation Hospital, and the Rainbow Children Hospital. So, ma'am has specialization in the ART and infertility reproductive medicine, and IVF in PCO and POR and high risk obstetric. So, ma'am has leadership and also in life member of the ESAR and just a minute, my screen has covered. So, yeah, thank you so much, all the wonderful moderators. So, over to you, Santosh Gupta, ma'am.
Okay, how to share my screen? You have to give me the option. You have to give me the screen share option. In the
No,
meantime,
ma'am, you can share directly. You can share.
No, it is coming. Someone else is sharing.
Bhakti, please stop your sharing.
Yeah, ma'am, you can share now.
No, it is not coming.
I stop sharing. I just see.
Yeah, it is.
Now let me see.
Ma'am, may I share? Okay.
I think 1 minute. Is it visible now?
Not it, ma'am.
Not it.
See, share option is, I have to click on share. Now?
Yes, ma'am. It's quite visible. Just loading. Okay.
There are
It's
multiple
visible.
windows. I have to make it full. Okay. Yeah. So I think we are late for the panel today. So we'll try to do as much we can discuss today. So the job given to me is the PCOS demystified, and me and Shilpa will moderate together. Before we start, I think I must welcome our experts today, my dear friend Dr. Lavanya and Dr. Anuradha, and they will guide us what is right or wrong, and we have a elaborate list of panelists. So whenever we talk about PCOS, it is always a disorder of access, and I think we must not forget that moderation is always good. But there is a saying by Oscar Wilde which says that moderation is a fatal thing, and nothing succeeds like excess. And our ancestors were so wise that many thousand years before they said Ati Sarvatra Varjayet, excess of everything is bad, and that's what PCOS teaches us, that excess of everything is bad. Although there are plenty of egg, plenty of hormone, but there are a lot of health problems. And the global prevalence is very high. It varies from country to country or geographical region or a racial variation. There's a global prevalence of 2 to 26%. Roughly 1 in 15 women worldwide is suffering. And why it is very important to sit at this forum and discuss about PCOD is because it is the most common endocrinopathy of reproductive age group female. 6 to 13%, these are WHO statistics. 6 to 13% of reproductive age women are suffering from it. Up to 70% remain undiagnosed. So that means diagnosis is very important. It is the most common cause of anovulation, one of the main cause of infertility. There are long-term consequences, and it has many other problems other than menstrual disorder or infertility, like metabolic disorder and cardiovascular system. And it does not stop at one level of reproduction, pregnancy. It affects a young girl with acne, hirsutism, with about psychiatric disorder, anxiety. There's a sexual health problem. There's a infertility. There is a pregnancy complication. There's a high risk of diabetes, cardiovascular disease, then endometrial cancer and everything. So not only it is in the forte of gynecologists, a pediatrics is involved, dermatologist involved, gynecologist, endocrinologist, then cardiologist, and maybe geriatric medicine doctor is also involved. And we all know about the metabolic disorders, that PCOD is closely associated with obesity, hypertriglyceridemia, blood pressure, and abnormal OGTT or diabetes. And not only it causes metabolic disorder, but it causes higher incidence of depression, anxiety, eating disorder. There's a higher incidence of obstetric sleep apnea. There's a higher incidence of non-alcoholic fatty liver disease. There's a lot spoken about it nowadays. There is a insulin resistance, there is a diabetes, there is hirsutism, acne, and higher incidence of cardiovascular disease. Along with that one segment, what we deal with it is irregular menstruation, miscarriage, infertility, and later on probably endometrial hyperplasia and higher incidence of endometrial cancer. So this is a population-based studies which has elaborated that all kind of disorders are many-fold higher in PCOD people than in the general population. So, and we all know, because we are all infertility people, we deal with recurrent pregnancy losses, that abortion rate is higher in the PCOD people, maybe because of weight, maybe because of higher LH, poor egg quality, and many factors. So one by one, we are going to discuss with the help of our expert and panelist. And the baseline in today's time, what we were talking about enigma, I think 2023 guidelines have made it very simple. As madam was also telling, after guidelines are laid upon, things become much more easier. So it is not that enigmatic. So here I begin my questions with our expert, Dr. Lavanya and Dr. Anuradha, and our panelist, Dr. Vidya, Dr. Ashwini, Dr. Shavis, Dr. Chandana, Dr. Sujay Hiranjul, and Dr. Rubina. I tried collecting people from all over Karnataka so that we can discuss together. So this is a very simple case. Dr. Shilpa, are you there? This is a 25-year-old female.
Yeah, I'm there.
Anxious to conceive with a history of delayed period. And she has few scans from outside, which has been mentioned that she is PCOS. Semen factors are almost normal. BMI is 28. So as we discussed in the beginning, the most common problem is undiagnosed PCOS. And being in metro cities, I think we are suffering from overdiagnosis. So how to proceed with the diagnosis? Anyone can take up the question. Hi, who will start answering, Dr.
Ma'am, I'll start, Shavis.
Please start.
So, ma'am, there have been like some 2-3 diagnostic criteria have been there, but Rotterdam is used very commonly. And clinically, when we look at this patient, that profile that you have said, she has had irregular cycles or oligomenorrhea, and she also has outside scans showing a PCO morphology, but we would like to confirm that with the transvaginal ultrasound. And since she's married for 3 years and she's been trying for infertility, so in the Rotterdam criteria, they say that they'll have menstrual irregularity or features of hypoandrogenism, which we can ask and also clinically examine. And then if our scan shows a polycystic ovarian morphology, then if 2 out of 3 factors are there, then we would probably label her as a PCOS.
So what do you mean to say? The clinical history is important, general physical examination is important, and a valid scan is also important. Any random scan will not confirm the diagnosis of PCOS. So when we talk about menstrual irregularity, how do you define menstrual irregularity?
I can answer.
Yeah, please.
Ma'am, so menstrual irregularity is usually defined, since most of us are dealing with the female in reproductive age group. So more than 21 years of age, it is usually defined as cycles which are irregular, that is more than 35 days in length, or less than 8 cycles in a year. That is usually defined as anovulatory cycles or menstrual irregularity. However, in the 3 years post menarche, the same period can be extended up to 45 days. Up to 45 days, it can be considered normal. And according to the ESHRE guidelines, like they have told that if you have a clinical symptoms of hyperandrogenism, mostly clinical as well as anovulation, that is usually enough to make a diagnosis of PCO. But yes, an ultrasound should be taken as a supplementary technique in order to confirm the diagnosis. But ultrasound per se for diagnosis is used if both the symptoms are not present. But if there is a history of clinical hyperandrogenism as well as anovulation, then ultrasound can be used as an added modality to confirm the diagnosis.
If she was an adolescent girl, let's say if she was 16, 17-year-old, then your menstrual irregularity definition would change?
Yes, ma'am. Then it will be, the cycles can be, if it is near menarche, then it will be more than 45 days. So less than 21 or more than 45 days cycle is considered as a irregular menses.
Okay, so the only thing I would like to stress here is, if you see an adolescent girl, we are discussing here with the infertile women, but if you see an adolescent girl, first year of menarche is any kind of irregularity is okay. 1 to 3 years is 21 to 45 days, and after 3 years it is 21 to 35 days, and adult is like 8 years after menarche. So they have used a very good word like gynecological age, like after menarche 8 years. That's how it is important. And PCOS, that scan also has a role after 8 years of menarche. So when we all were talking about the scan, one of you can take up the question, what is the ideal scan for diagnosis of PCOD, or how will you?
Santosh, before do you want to move on to the scan finding? I think another point that we need to add is 8 periods in a cycle, in a year.
Yeah.
Is also something very important for an adolescent. Along with what Shaiza told, almost 21 to 45 days. I think 8 periods in a year is also something very important that we need to consider.
Yes. Yeah. Less than 8 period per cycle is irregular cycle. And yes, correct. So that's why we have experts here. So the adolescent, we should not overdiagnose, because most of the girls who come with, they'll say in my early days, I was diagnosed with PCOD, and they have that baggage of having PCOD throughout their life. So that is very, very important. Dr. Chandana, you want to tell us about the scan finding in the PCOS or PCOD, because
Yes,
what is the
ma'am.
ideal scan and how should we proceed and what should we look for?
So, ideally, when we do a vaginal scan using a frequency of 8 megahertz, so we report it as follicular number per ovary, which is FNPO. So what we measure is, at least in one ovary, there should be more than 20 antral follicles, or per section. So FNPS should be 10, or the ovarian volume should be more than 10 cc. So in either of the ovaries, then we call it as a PCOM ovary. So, but when we are also doing the scan, we should make sure that we are not looking at any. So when we are calculating the ovarian volume, there should not be any ovarian cyst. There should not be a dominant follicle. There should not be a corpus luteum. There should not be any hemorrhagic cyst. So we should always make sure of that, and always measure the ovary when we're taking the volume in 3 dimensions. And also always look for any uterine or endometrial pathologies.
Yes, so basically Dr. Chandana has made few points, that is, features in one ovary is sufficient. That is number one. Number two, it has to be a transvaginal scan, and you should rule out any adnexal mass when you report about the PCOS. These are main criteria, I think. And one more thing I want to ask here is about, lot of people talk about ovarian stroma, that ovarian stroma, its volume. So that is not a diagnostic criteria. It is basically the ovarian volume or follicular number per ovary. And the scan doesn't fix up the diagnosis of polycystic ovary. It's just that we give the diagnosis of polycystic ovarian morphology. And scan is neither necessary for the diagnosis of polycystic ovary. If two criteria are already there, we can even skip scan to diagnose the PCOS. I would like to ask our expert what opinion they have about it. Dr. Anuradha, Dr. Lavanya.
From my side, I think it's just the perfect criteria is given. Only one point. I mean, ultrasound is not required, but then the only confusion comes when we have a multicystic ovary. That is where the stroma matters, because in a PCO you have a typical that pearl appearance, in the periphery. So in the multicystic ovary, it's like spread all over. The stroma is much lesser, and I think that's very important. Though they don't mention in the criteria the stroma is included, but I think that's something very important for us. But otherwise, I think all points taken and noted, and that's the
prognostication
perfect one.
also with stroma
Yes,
it is
perfect,
important,
yeah.
but it is not
Yes, it is
included.
important.
And
Yeah,
one more
it is not
important point.
included.
I would like to add one point here that though we don't have the stromal description here, but we know that PCOD is, it has insulin resistance. Most of the PCOD patient will have insulin resistance. So if there is thickening of stroma, without even doing your insulin values, you know that this patient has insulin resistance. So I always look for a stromal thickness. I do look for that. So that gives you an indication.
So that is a wonderful point. See, if you are doing your scan, that means if your scan is done by a learned person who is aware about the disorder, then fine. What we are most of the time getting a scan from outside, and every ovary is labeled as a PCOS ovary. But in guidelines, stroma always tell us about how bad the PCOS or insulin resistance, but it is not one of the criteria. And one more point I wanted to mention here, because the latest guideline says 20 follicles and above, and the old guidelines used to say 10. So if your scan machine is an old scan machine, that is with a lesser Hertz probe, it is lesser number of follicle. If it is an advanced machine, then it is a higher number of follicle. Anything you want to add, Dr. Lavanya?
Even the hypervascularity, I always put a Doppler. Even the hypervascularity of the stroma will indicate insulin resistance. So these are three extra things which I do without even, because I don't do fasting insulin levels. I mean, it's not recommended. So I do know, and then I straightway start metformin in such patients.
I would like to add a point.
Yeah.
Sometimes we see multicystic ovaries. The peripheral arrangement of the follicles may not be seen. In such situations, that could be a precursor of obvious PCO in future in the scan, I feel.
Yeah. Actually, the stromal thickness or stromal finding will give us the severity of the disease.
Yes.
If multicystic ovaries there, that may be initial stages, and later they change to a resistant PCO. And
exactly.
These findings are nowadays, many adolescents are labeled as PCO, and they are very scared of this diagnosis. So it is really a request to everyone that you should not label them like this. You should wait for the criteria as they have given.
So it is written clearly in this guidelines. There is no definitive criteria to define polycystic morphology on ultrasound in adolescent. Hence, it is not recommended for adolescent. So, and regarding 10 follicles and more follicles, it is the newer machines are more advanced, so we can report as a higher follicle. If you are still using a old machine, then it is our older definition.
Ma'am, I just want to add one more thing. Usually, when patients who have irregular cycles, if they are young or if they are old, and by chance they are obese, God forbid they are obese, they will be invariably labeled as a PCO. They may even be having, on the contrary, lower ovarian reserve, but still, with the trans-abdominal scan done by a general radiologist, they will be referred as a PCO, and they will think that they have a lot of time to conceive. Gynecologists will think they have a lot of time to conceive, but at the end of the day, when you do a TBS, you find that the ovarian reserve is actually contrarily very low.
Yes.
Yeah, it is more we see this very often. So in all cities where scan is available, that is a problem. I had one patient and and AMH will come 0. And they will be thinking that they are PCOD, and even if their periods become early or irregular, they still think they are PCOD.
When a radiologist does the scan, invariably the report is PCO.
Yes.
No, I think that is why the Rotterdam also made that 2 criteria of the 3 is very important. And I think it's very,
Yeah.
That's why scan done under your premises is very important, I think.
No, not even premises. I think scan
Done by
done by
ourselves.
yourself.
Ourself.
Yourself is the most important. Forget the premises. Done by
Yeah,
yourself, I
suppose
think
if-
will add a lot of value.
Yeah, correct. So I think scan criteria we all have discussed and we all have understood it well. The more difficult part, another thing is AMH. What is your take on AMH? Do you do AMH for everyone for diagnosis or how it is?
No.
Dr. Vidya, you can answer this.
No, I don't do the AMH for diagnosis of PCO.
Okay. So, but it helps. Like if PCO, if it is high, it can help.
It helps only for a patient to predict hyper response for me or hyper response for a poor responder. But for diagnosis of PCO, I have never done AMH test. But
So that
criteria
is-
says that with ultrasound you can do or AMH also. High
So
AMH.
this is wonderful. That's what guideline says. AMH should never be used as a test to diagnose PCOS. Many people started using it because it becomes very easy to interpret. But AMH is not a diagnostic test for PCOS.
Even I have seen people giving diagnosis with higher LH levels, FSH, LH they will do with every PCO patient. They will do ultrasound, AMH, FSH, LH, testosterone, and FSH, LH is high. People are explaining that high LH is there. That means you are having PCO. So
No, there is
we are
nothing
not
wrong in
given.
that, Dr. Vidya. What happens is, see, you, me, and many people are doing scan bar ourselves. Sometimes those who are not doing scan on themselves, there is a criteria called biochemical hyperandrogenemia. In that, although LH is not recommended as first line test, but high LH can be one of the marker of biochemical hyperandrogenemia.
Yeah.
So what we were discussing about AMH is that it is not the sole test. It should not be done. It can vary in the patients according to the cycle. High BMI patient can have low AMH. I think Lavanya wanted to say something.
No, I wanted to say that, of course, AMH cannot be used as a single parameter. It's something that needs to be used in association with scan, and this is only used for counseling of the patient. So how would they would respond to the whole treatment? In fact, I would also try to assess that how resistant they are to the treatment. What would be my dose? What would be my starting dose and how many dose they would need? Or I could be monitoring them for 21 days. I think it's very important for us to remember that PCO, we need to monitor them for a longer duration. Unlike our other patients who would respond or ovulate at the 14th day, same thing may not happen to a PCO. She may be
one thing I
ovulating
would
at the
ask
20th
Lavanya
day.
here. So
Yeah.
So higher AMH means they are
More
very
resistant.
high AMH means they are
Yes,
more
I would say
resistant.
more resistant. Yes.
More resistant. So
Yes.
we should not get fascinated that they are more
Yes.
resistant people.
And also make it a point that don't increase your dose suddenly. Monitor them coolly, escalate it very slowly. And I think patience is something very important with PCOP and patients. PCO and patients, I think, goes a long way.
I would like to add one point in this. Obviously, for the diagnosis purpose, yes, AMH does not have that much of value. But to talk about practical issues, especially when we are dealing with patients of infertility and we go to so many remote areas for camps where every doctor does not have so much of scan facilities, and because to reduce the risk of misdiagnosis in infertile patients where the facility of scan is not there, I advise them to just do an AMS to confirm your diagnosis because of the restriction of other modalities available.
I think it's a very practical point. Very practical point. So apart from scan and AMH, see, we shall not forget 2 criterias of diagnosing. One is clinical and biochemical hyperandrogenemia and menstrual irregularities and anovulation we have discussed. So I want you to tell us that how do we diagnose clinical hyperandrogenemia or biochemical? So what are the features in clinical hyperandrogenemia which are important?
So clinically,
mainly acne.
It is hirsutism, which is the most important factor of clinical hyperandrogenemia. And alopecia and female pattern baldness, they are rather weak predictors, but yes, they also are predictors of clinical hyperandrogenemia. So if in case of hirsutism, if the modified Ferriman Galloway score is about 4 to 8, then you need not have to confirm it with a biochemical hyperandrogenism. However, if the but again, because you have to take a detailed history where you have to rule out that patient has not taken any facial treatment to reduce the hair, that all clinical history is required before you examine the patient for your hirsutism. And if hirsutism is not there and there are other factors like acne or female pattern baldness, then you might have to confirm it with the biochemical hyperandrogenism, which is mainly testosterone and free testosterone.
Ashwini, you want to add anything here? Ashwini?
Madam, usually clinical hyperandrogenism we suspect with hirsutism and acne. Biochemical hyperandrogenism, best thing is to do total and free testosterone. If that is not available, we can also do DHEA. But total and free testosterone is something that is recommended to be tested, and especially by mass spectrometry.
Okay, so
but I think if patient has just hirsutism, she has hyperandrogenism. I think hirsutism, you can see the patient walking. She has hirsutism. So you will make, and if she has along with other histories, regular cycles, and even obesity along with it, especially the abdominal
And
area, the
also
truncal obesity,
acanthosis.
what we call, yeah. These are all associated with this problem.
Acanthosis.
Yeah.
Can I add a point?
Acanthosis.
Sudden onset and
For Indian
accelerated
patients, I have
hair
not
growth
seen
is
much
something we should
acanthosis
be
because of our
careful
culture.
about. Sudden onset of hirsutism and accelerated hair growth is where we have to be a little careful and evaluate for other reasons for
yeah, that is a very
hirsutism.
good point Dr. Shilpa has made, because that's why history is very, very important. And one more point Rubina has made earlier: never get fooled by the appearance, because the girl, she's a young girl, she would have used all the cosmetics things, laser or waxing, and also just by you have to ask them that what face you are showing, it's a natural or you have done some kind of hair removal cosmetics. So they would have used, a young girl in any age would have done that, right? So these 2 points are very, very important. If there is a sudden increase in hirsutism, then obviously we have to check for these blood tests. So
Ovarian tumors, Cushing syndrome,
Androgen secreting tumors.
androgen secreting tumors.
Yeah.
Ovarian
So if we go back to the diagnosis at all levels, the PCOS is a diagnosis of exclusion as well. If you see, there's an exclusion of other etiology, exclusion of other etiology.
Yes.
So if you have slightest of doubt, you have to do it. So basically, in a biochemical markers, we are doing testosterone and free testosterone. And as Dr. Ashwini said, it has to be done with a advanced method, mass spectroscopy. And anything else you want to add on this, Dr. Chandana?
A free androgen index also sometimes will help us in the diagnosis of biochemical hyperandrogenism, ma'am. In case, we are not able to make the diagnosis with a free or total testosterone, that can also be added.
Yeah,
And the prolactin level. Prolactin
Yeah.
level is also important.
Yes, prolactin, thyroid, all other associated tests are also important in the diagnosis of PCOD. So these are the markers of biochemical hyperandrogenism: total and free testosterone. Mass spectrometry is preferred over direct immunoassay. Another thing is patient should be pill free. When we are doing them, the biochemical markers, can anybody tell us why they should be pill free for 3 months when we are doing?
So basically, it has an effect on the
Because the
SHBG
pills
levels.
can affect the levels of
androgens.
Yeah.
SHBG.
Yes. And then usually testosterone is high at puberty and it settles down at 12 to 15 years. So it is not a very good test as a pubertal level. Repeated measurement of testosterone are not required. If testosterone is normal, then you can measure DHA and other tests what has been mentioned. And what Dr. Shilpa has told, rule out iatrogenic ovarian tumor, adrenal tumor, congenital adrenal hyperplasia, and Cushing syndrome if these values are higher. So this is the diagnostic algorithm for PCOS. So if you have irregular cycle and clinical hyperandrogenemia, then you need not to do any test and scan for the diagnosis. For treatment, maybe you need it. If there is no clinical hyperandrogenemia, then test for biochemical. So a clinical history of period plus biochemical test, then still you don't need the test. And ultrasound, basically, I think in urban area and the kind of practice we do, patients will not believe us without scan, but ideally speaking, if two criteria are there, then the scan is not required, and request for ultrasound for PCOM only in the adults. In adolescent, it has no meaning. And there is a lot of metabolic disorder associated with the PCOS. So same lady I told you with a higher BMI. Dr. Shilpa, you want to take over the question now? What are the tests you will do for metabolic disorder?
Yeah. Shaviz, can you answer about this? Metabolic disorders, what are we looking at in case of patients with PCOS, starting from adolescence to old age?
Ma'am, we have to, when we're like discussing with the patient, we have to ask her for any history of basically hypertension. Say in adolescent, they will have excessive weight gain to begin with, and probably a little later in life, if they have any history of hypertension, or if they have any obstructive sleep apnea, history of any snoring that has been noticed by the say partner or anything like that, and history of any diabetes, or we have to also do her tests following the clinical in this one. So we have to do her oral glucose tolerance test ideally. If they cannot do that, then we can also do a fasting blood sugar with HbA1c. And once that is seen, and if it is normal, then it's fine. Otherwise, we might have to screen them even yearly if they are at a higher risk for diabetes mellitus. We can also ask them whether they have any male partner, like male family members who are at risk of metabolic disorders, because that is also linked to the first degree relatives who are males. And probably we have to also keep in mind the risk of cardiovascular disease. So we need to screen that also if they are at a high risk for that. And a fasting lipid profile also can be done.
Okay, that's perfect.
So I think in this, the message is whether you have an adolescent or adult, the glycemic index should be done. Ideal test is OGTT. Or if the patient cannot do, then HbA1c and or the fasting sugar, and lipid profile has to be done. Lipid profile has to be done for the patient. One single test for the cardiovascular disease, if we do, the lipid profile test has to be done. And insulin resistance testing earlier we used to do, according to these guidelines, it should not be done. Any comment from anything you want to add on, Dr. Chandana, Dr. Vidya, anything you want to add on?
I think all of it is covered.
Okay. Lavanya, any expert comment from you?
I think it's good. Yeah, it's fine. OGTT, I feel it needs to be done, only if it's altered, then to add metformin. Otherwise, nothing much for me to comment here. I think it's all good.
It's all good. So OGTT,
I have a comment, Dr. Santosh, if you don't mind.
Yeah, please.
I think clinically on the OPD basis, doing a OGTT is a painful thing, isn't it? I think I hope all of you agree.
I know.
I know guideline says that, but what would the panel tell that? Is it okay that I do only HbA1c and FBS?
I do fasting blood sugar and HbA1c.
Pardon?
I do generally a fasting blood sugar and HbA1c in my practice.
I agree to Dr. Ashwini. The moment patient comes, I also do HbA1c and FBS.
Yeah,
in fact, they may not be fasting. I'll even do a random sugar.
I mean, it's nice to
you
have
don't
the
want to
idea.
miss it. Yeah, you don't want to miss it. So one random sugar,
Correct.
HbA1c.
Opportunistic.
HbA1c gives us the 3 months backwards. So I agree with Dr. Ashwini. But
No,
the
same
guidelines
usually
you have to do OGTT. Yeah.
Usually in our center, we also club it with serum insulin, both fasting and 1 hour, because so many times along with the OGTT, And what we have observed is a lot of times it's the serum insulin is way much higher, although the OGTT is normal. So that also gives us some insight as to what is happening with the insulin resistance.
The only problem, Dr. Ashwini, is that, interpretation becomes a little dicey. When guidelines say something else and we are doing something else, there's no uniformity across consultants and all. Yeah, I totally agree. I mean, for ease of treating, for ease of coming to a diagnosis, what you said is absolutely fine. And also, for the ease of on a OPD basis doing a OGTT or asking her to come again later, or for her to spend 2 hours at the clinic, which most of them don't have time. First of all, the moment they come and meet us, I think in another 5 minutes, as they go out of the clinic, they want to rush out. When most of us see that patients, they have something or the other to do. People don't have time now, and it is so difficult to actually, execute these guidelines, frankly speaking.
No, in guidelines also, I think they have recognized, they have written that it is a most accurate test, but OGTT cannot be performed, fasting blood glucose or HbA1c could be considered. So, and they have recommended that insulin test should not be done.
Yes.
It is recommendation, but in one of the panel, there was an endocrinologist. I was asking him questions, so he said they do it. Endocrinologists, they do.
No, sometimes we are stuck with our practice also. Like, over a period of time, we tend to develop some intuition or acumen or whatever that works for us. Right? It's hard to change.
I think when we want to start metformin, fasting insulin, if we have a documented report, it makes sense.
They do it to see the progress of how their treatment is working for the patient, like to prognosticate or that way, to see the progress of the treatment probably. And I think the OGTT is more in favor, like say a PCO patient gets pregnant and then early GTT we can do probably. And FBS, HbA1c when they are...
Pregnant patients listen, Dr. Shavis, that is true. Pregnant patients are also ready to do all the tests properly.
Because
when a young girl comes in, they just want to listen that there is no much issue, what should I do? And then they're done with it. Whereas
So many times what we see is, the OGTT abnormality comes much later than what the insulin resistance has already developed. So that can be picked up much earlier. The insulin resistance can be picked up much earlier, and
it could be individual practice, but in general, none of the guidelines support it for PCOS.
Yeah, guidelines may not support.
And OGTT, if it is impaired, or it can pick up little early then. But yes, in my general practice also, sometimes for pregnant patient to do that OGTT test is not possible. They are happy doing HbA1c. So, and same with the day 3 scan also. No, ideally we should do all scans on day 2, day 3. But if patient comes on 7th day or 15th day, if it is an obvious PCOS, we understand that it is PCOS, like that. Anything from expert side, anything to be added on this?
I would say I agree with you, Santosh. I think it's very important in pregnancy, infertility. When we do our scans, when we do our blood tests, I think it's very important. And I agree with you.
Yes. And regarding cardiovascular disease, we all understand that PCOS have a high risk of cardiovascular disease. And then should we do their health checkups regularly? Should we send them to cardiologists? What should we do, or physicians?
I think you can do a lipid profile as a baseline. If it is abnormal, definitely refer them to a physician. Otherwise, the routine check of a BP or a lipid profile, and as it is, you're doing HbA1c and a fasting blood sugar. So if things are under control, we may not have to refer them, but you have to sensitize them that they can, in due course of time, develop cardiovascular disorder, and they have to be on a check for that.
Yeah. So that is a very precise answer. Lipid profile is mandatory, and then sugar test is mandatory. Whatever test you prefer can be repeated 1 to 3 years, and they should be counseled. But overall risk of premenopausal cardiovascular disease or mortality or morbidity is low, so they need not to be. And the one blood pressure check is mandatory. blood pressure check is mandatory and annual BP check is recommended.
I think the overall way of putting it across for a PCO is be like lifestyle modification. And I think we need to remember to tell all PCO patients 30% of them will end up having either hypertensive, diabetic in their later life. So I think lifestyle, bringing up that lifestyle modification is something very important, even when we see them as a fertility patient.
Yeah, so always the first line management will be lifestyle. So Chandana, can you elaborate how do you counsel a patient for lifestyle or losing weight? How do you counsel your patient?
So it involves both diet and exercise, ma'am. So diet, there are various kinds of diets which can be advised, like Mediterranean diet, ketogenic diet. But the simple way is to tell them to do a time-restricted eating. Though the guideline mentions more about Mediterranean and ketogenic diet, so for our population, tell them that, limit your eating window, eat only in a limited window, because the fasting status decreases, enhances the insulin sensitivity and decreases the insulin resistance. So that is about the diet. Along with that, they also have to incorporate some exercises, so which involves both weight maintaining and weight loss. So if they're targeting more towards just weight maintenance, then it is at least around say 200 to 300 minutes of moderate exercise per week, or around, which includes walking, brisk walking, cycling, or swimming, or 75 to 100 minutes of vigorous exercise, which involves some kind of aerobic exercises. So if they're looking at a weight loss regime, then it is again around 200 minutes of 200 to 250 minutes of moderate exercise per week, and around 100 to 150 minutes of vigorous exercise per week. So we have to tell them the importance of both diet and exercise.
Shall I add?
I think counseling is very, very important in COD patients, because I always tell one thing, that it has lifestyle change has to be a part of your routine. You're not supposed to do it just for a short duration. It has to be inculcated in your lifestyle, just like you sleep, you eat, you exercise. I think that is very, very important, because even if you are not obese now, you will eventually become obese if you don't follow a healthy lifestyle, and that will again cause the eruption of symptoms. So we have to be very, very careful while counseling the patients, and lifestyle, like everyone, like Madam has told very clearly, it becomes a very important part of their regime life.
For dietary counseling, if you refer them to any dietitian or advise any diet, it is difficult for everyone to follow that dietitian or somebody, or they cannot afford. So I usually educate the people that you should have high proteins, low carbohydrate, and high fiber. And our whatever patients coming to us, they are not knowing what is protein and what is carbohydrate. So it is, we should tell them what are the protein food we have in your diet, what are the carbohydrates. Accordingly, you should plan 1 or 2 meals for them. Then they can follow better, and give them.
Yeah, that is very important, because one of our panelists told Mediterranean diet. Even I don't understand what is Mediterranean diet. So we have to tell patients in the language what they understand.
And we should give them realistic goals. We should measure, because weight reduction in one day is not possible. We should measure them inches, and inch loss is first. So they will be happy, and they will stick on that whatever diet.
So what goal you give them? 5%, 10%, 20% of the body weight? 5 to 10%.
But I first tell them that waist hip ratio you monitor, and monitor that ratio in 1 month. How the measurements are reducing. Because
and we should tell them in metro cities like Bangalore, how much a pizza has calories, how much of a Coke has calories. We have to sensitize them. Maybe 1 or 2 sessions once we diagnose PCO should go on with the dieting, especially in corporate culture, where they just sit and have one pizza and one Coke, and that is done. They think they've eaten less, but it would have added almost like 1,500 calories. So such calculations and some leaflets in the OPDs, if we distribute, it will be helpful.
But there are some lot of practical problems over here. Basically, because the patient is already diagnosed as PCO by several of the other doctors, she's already had an overdose of how her lifestyle should be, what her diet should be. She's already in a depressed state. So consistency and maintenance of such a diet is very difficult for her. So majority of them actually fail at this stage only. The lifestyle
No,
modification
that's why
itself
it is
becomes
the
a
first
very
line
quick challenge.
management. It is first line management. Most of us get patient when they have done everything. So we cannot be disposing patients or refusing them that you are obese, come after losing weight. I had one patient who threw file almost on my face, and she told me that if you are also going to reject, she was 130 or 120 kg. I am not ready to sit, I'm ready to go, I won't do registration because she has done everything. So I accepted it, we did an IVF. So it's a first line management we are discussing.
Yes.
Yeah.
Yeah.
I think
Santosh, me being on all sides of the weighing scale, I would definitely say it's something very difficult to follow. Then it's like advice is more easier than following it up.
Yeah, definitely. Definitely.
Definitely.
And
So since you've also been consistent on your weight, it's easy for you to tell somebody who's across the table. Maybe it's more relatable to people like us and my patients, especially when I say, look, this is the healthier way of doing. And very important as a fertility doctor, we have to remember we can't say 1/3 protein, 2/3 this thing, 2/3 that thing. It's not going to work. I would always say a practical tip is keep a dietitian specially for this. And then we say lifestyle, we need to importantly try to escalate that it's both diet and exercise. Keep somebody follow up with them on a regular basis, make a calls compulsorily, weekly basis, see what is their progress, and always give them achievable targets. Most of you on the panel have been all on the slimmer side, so I think achievable targets is for every patient, because you say 2-3 kgs, I think it's impossible until unless you're doing it the nonsense way. But then if you do it the right way, I would say 1 to 2 kg is the best achievable target that you need to give to your patient. And being sensible as a doctor is very important as an advice. And I would say this is my last comment. I'll have to exit because I have another pre-commitment. Please kindly excuse me. Dr. Santosh, congratulations on a wonderful conference. I think Dr. Sonia Malik was a great choice. Panel is really excellent.
Yeah, sorry,
And
my connection, everything got disconnected all of a sudden. So
It's a wonderful webinar and with all the good panelists and very good moderators. Yeah.
Ma'am, on that diet note, till ma'am is connecting her slides back, I think the first thing we need to tell the patients is to stop sugar. They have to stop white sugar. I think that itself will bring a drastic, beginning of the weight loss, and then they'll get more motivated, hopefully. So I just tell them at least stop sugar. Otherwise,
I tell them to avoid all whites in diet, like rice, maida, sugar.
I tell them to go back to your ancestral diet. See, I always tell this intermittent fasting is something we people have made it. But if you talk about the ancestors, they used to eat at 7 o'clock and they used to eat in the morning. So now we tell them, okay, this is the intermittent fasting. But personally, I'm a big propagator of intermittent fasting, not only for the PCOD, but in general, because of their huge health benefits. So I just tell them, just go back to your millets, go back to your ancestral diet. That should be enough.
I think we should conclude this session, but I wanted to show one slide. PCOD, there are a lot of research has come which says that PCOD is related to gut microbiota. That means there is a concept of prebiotic and there is a concept of probiotic. So if you do not eat appropriate food, your gut microbiome or gut microbiota will change. And because the gut is involved with the metabolism of all our steroidogenic hormone, estrogen, progesterone, cholesterol, everything. So PCOD induces inflammation, it induces metabolic disorder, it induces hormonal disturbances. So there is a lot of relation between the food what we eat, what our intestine perform, and what PCOD or hormonal disturbance we get it. I think we are running over time. So Shilpa, with your permission, shall we conclude the panel now?
Fine. I will just give a last comment. We have all these newer drugs for weight reduction can be considered when nothing is working. With that, I would like to conclude, like semaglutide, Monjaro, all those drugs are definitely there when nothing is working. Yeah. So Santosh, thanks a lot. It was a very good program. good panelists and good speakers, I think we should wind up the program. Thanks everyone for joining.
Thank you, everyone.
Thank you, guys.
Thank you.
Bye-bye.
Thank you,
you.
everyone. Thank you very much.
Thank
Thank all the panelists to come forward and experts.
Thank you. Thank you so much. Thank you.
Thank you.
कोई कॉल कर रहा था आगे रिकॉर्डिंग स्टार्ट है अभी स्टॉप कर दूं एकदम आज
Recording stopped.